The information provided on this podcast is for general informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your qualified healthcare provider with any questions you may have. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. Reliance on any information provided here is solely at your own risk. Welcome to the Birth Baby Podcast. Each week, you'll find guidance, encouragement, and practical tools to support you through pregnancy, birth, and the postpartum journey. I'm your host, Sierra Morgan, a certified birth and postpartum doula, hypnobirthing educator, and pediatric sleep consultant. I'm also the owner of a doula agency in Austin, Texas, and the founder of the Birth Baby Academy, where I offer classes for both parents and birth professionals. Thanks for being here. Hello, everyone. Today I have MJ Saunders with me, and we are going to talk about ultrasounds. With over 15 years of experience as a registered diagnostic medical sonographer, she has dedicated her career to providing compassionate and high-quality ultrasound imaging, and her journey into sonography was fueled by a lifelong passion for the medical field and a deep desire to connect with families during one of the most exciting times of their lives. And if you ever meet her in person, and you'll probably be able to hear it today, she does have that passion. You can tell just by speaking with her. And she has a company here in the Austin area called See My Baby Live. I hope I said that right. Thank you so much for being here today with me, MJ.
Thanks for having me. I'm super excited.
I'm excited too, because this is something that, ultrasounds, especially in this day and age, I feel like we're all much more careful about our health and the things that we put into our body. And we're all becoming way more conscious. And that's a good thing. But sometimes it steers us away from doing things that maybe should be done or are recommended to be done by medical providers. And we get a little bit worried about it. And we're like, what is the truth here? So I want to start this episode out by telling parents, whatever direction you choose to go, if you do not want to do ultrasounds, I support you. Like, I am not judgy here. You guys should know that by now. But for parents that do not know, can you explain in simple terms what an ultrasound even is?
So ultrasound sends sound waves into a body. There's no radiation. There's no exposure. I have a probe right here. This probe is pretty fancy, has crystals in it. The crystals get excited. They get activated when we send a signal. It goes into the body and then it comes back to the probe, and the machine is able to process that into images. And it just depends on what barriers within our body that the echoes, that's what they're called, the echoes reflect from. And it's able to give us discernible images that we're able to evaluate. It's pretty incredible.
Do you know, it was a long time before I knew the difference between ultrasound and sonogram? Because you hear people use those two words interchangeably, an ultrasound and a sonogram. But I think I'm right. Is it the ultrasound is the process of what you're doing and the sonogram is the picture?
Yes, actually, you're right. And people use interchangeably. It's kind of like a technician and a technologist. A technician works on the machine. A technologist works the machine.
Oh, see,
I know, right?
Really specific here, guys. Okay. So people also are really worried about x-rays. And we hear that we're not supposed to get x-rays during pregnancy, but an ultrasound is not an x-ray, right?
Correct. No radiation. In different environments that I've worked in the past, pregnant mamas may get an MRI, which is magnetic resonance. Again, not radiation. It's just a different way to image. And one thing to think about, all of the like ultrasound or even MRI, if that's something that's recommended to you, they're only there to help evaluate the baby, to give you as positive outcome as possible. It's not a conspiracy. It's just to help.
Yeah. And so that is something that people are worried about is exposure, right? Like even to ultrasound, they hear like maybe I shouldn't get very many, or maybe it's bad to get too many. Is there, what do the studies say, if you know, about ultrasound safety and how many are safe to do?
That's a hard thing, because kind of what you referred to in the beginning when you said you respect everybody's viewpoint and their choices. You look up anything online and you're going to be able to find a viewpoint that either aligns with what you want or a
True.
viewpoint that differs.
On
That's
everything,
just
right?
everything. And
Yeah.
ultrasound is no different. But things to think about, it is sound waves. Babies can't even really start to hear until like 14 to 16 weeks. And it's very muffled. Think of Charlie Brown's teacher, kind of like that. As they get to hear better and they're able to distinguish sounds, people have compared the ultrasound to like a subway, hearing a subway train coming, like the rumble. Like I'm so passionate about ultrasound that I feel like it's such a positive in people's lives, especially in OB. I sometimes feel like when people are all, it's going to hurt my baby. It's not going to hurt your baby. It's not going to hurt your baby's hearing. It's not going to expose you. And one of the biggest things, if no one takes anything away but this one point, when the picture is frozen on the screen and somebody is touching you with a probe, there's no sound going to the baby. And you have to think when you're doing an ultrasound, at least half the time that image is frozen and there's measurements being taken, there's no sound whatsoever.
Oh.
So while you think like a 45-minute anatomy, maybe only 20 minutes of that is actual movement on the baby.
Oh,
so
that's
if that
interesting.
helps
I didn't know that.
yeah, if the image is frozen, there's nothing going on.
Oh, cool. Okay, that's neat. Okay, so it's only when that is going. All right, that is really helpful. And I work with a lot of high risk moms or a lot of moms that have tried really hard to get pregnant and experienced a lot of loss. And man, do those mamas love an ultrasound. I mean, if they are given an opportunity to have one every week, they're like, yes, sign me up. I would love to see that sweet baby every day if I could, and it can bring so much peace of mind. So that's nice for them to know that like these little, the quick ones where they're just checking really quickly on safety and blood flow to the cord or whatever, that they're able to maybe have a little bit more peace of mind about that. So what are the typical ultrasounds that are just in a normal healthy pregnancy with no extra risk? What are the typical scheduled ultrasounds and like what's the purpose of them, each one of them? Can we go through them?
Sure. So at my clinic, we provide both elective and diagnostic. So I'm only going to touch on diagnostics at this point.
I told our guys that we need to have a whole nother episode about all the fun elective ones that we can do.
Right. So a diagnostic dating, we would want to have done ideally around 8 weeks. And during that time, we're going to measure the crown rump length, which is the top of the head to the bottom, and get a heart rate. We also look at the uterus, make sure everything looks appropriate in the uterus. Is there any type of subchorionic hemorrhage or a bruise, any type of bleed, even just to give mom a heads up, she might have a little bit of spotting, or to be alerted if it's a big bleed. We look at the
fibroids?
ovaries.
Can fibroids be seen on that one?
We can. Okay. We can. And I have spotted fibroids before, and it explains a lot. Not to deviate too much off the subject, but some of the things with fibroids is the biggest one is pain during intercourse that you feel during that fibroid, or when that fibroid is kind of activated, picking up. So someone who has fibroids might bend over to pick up their kiddo and they might have an ache, or pick up anything and it might be a little achy. Of course, you get some of the irregular bleeding too, and you can have that as well during pregnancy. The one thing that we would check is to make sure those fibroids aren't anywhere near the cervix, because that could infect the integrity of the pregnancy. Okay,
cool. Thank you for answering that.
So, you're welcome.
I didn't tell her I was going to ask that.
Fibroids, eek. So the dating ultrasound, crown rump length, heart rate, uterus, ovaries, we check the adnexa, which is kind of the outside area that you would have of the pelvis, just to make sure nothing is behaving funny from the hormones that are coursing through your body. That can go, I've done a dating as late as 15 weeks, but ideally we would want that to be about 8 weeks. We do typically look above the belly if you're not matching up on your dates, or maybe you're a little heavier, or just babies you have like a retroverted uterus, so it might be kind of tipped a little back. We would use a transvaginal probe. And then the next one that's pretty consistent is the anatomy. And the anatomy is done from 18 to 21 weeks, ideally right around 20 weeks, because that's when we see things the best. We can go as early as 18 weeks, but again, mom's body habitus can be a bit of a hindrance if we do 18 weeks. 20 weeks is pretty ideal. But sometimes timing doesn't align, calendars don't really work out, and I've done those later too. There's not like a law, it's just an ideal that it would be done by 21 weeks.
It's making me giggle thinking back to being 24 and pregnant with my daughter. And back then, this is 15 and a half years ago now, when you got the sex of your baby, you were waiting until that 20-week ultrasound, that anatomy scan, unless you wanted to pay a lot of money for the other testing. And that was not happening. So I remember trying to schedule that early because I was hoping that I would be able to get it like at 18 weeks, right? I wanted to go on the early end because of that. But then they were like, well, we can't always see things as well. Like it's better to wait. Man, for this type A mama, waiting that extra 2 weeks was rough. But that's funny that now I'm hearing 15 and a half years later that no, Sierra, it was probably better to wait. You might have had to get it done again.
Yeah, definitely. We can see gender 14 weeks pretty consistently. Sometimes they see a little early, but you have to watch that tailbone because sometimes that tailbone can give the appearance of being male. But 14 weeks pretty consistently, and that's above the belly. I do want to touch on, just because we had kind of joked about it, this is a transvaginal probe. I don't want anybody to be afraid.
Hey, go on our YouTube channel. If you're on the phone and listening while you're driving, remember later to go and look at these funny little things that she's showing us here.
It's a little intimidating, but this is where the camera is. So this whole thing does not go inside of you. Like that much goes inside.
That's nice.
I know, right? I see sometimes people's eyes get very big when I pull it out. They're like,
especially
what?
You just pulled it out with the case on it, by the way, and held it like that for a long time. So for a long time, it looked like that whole thing was what was going in. So she took the top off, guys. It's okay.
And I do want to reassure you at my clinic, I do guarantee that we sanitize. We have a whole process that we follow.
I would hope so.
That's something to be aware of. Some places are a little less, or maybe they're more casual about it. But we sheath it. It's all kinds of good stuff. But it's more awkward, and you're covered the whole time. But when it's an early pregnancy, we look at that. If we're concerned about a cervical length, we look at that. If we're worried about in the anatomy, if it reveals that your placenta is low-lying, we usually look transvaginally too. You don't want your cervix and your placenta being close to each other. That can make it for a difficult labor, like a tragedy. So then they may have to take other steps.
Yeah, I'm actually planning an episode where I talk all about placentas and their locations. Because that's another thing that people ask about all the time. Okay, so far we have the 8-week-ish dating ultrasound. We have the 20-week anatomy scan.
Yes, so like 80 to 100 pictures, sometimes more, we take of that anatomy. So I'm going to rattle off a bunch of stuff. We look at cervix, placenta, how those two are related, the cord insertion, how baby is laying. We measure the head, we look at the brain, we look at the face, we look at the nose and lips. That's a really important view. It's called a tangential view. It tells us if there's any clefting. We look at the profile. We look at the spine, diaphragm, heart, like 20 different pictures, stomach, kidneys, bladder, cord insertion, abdominal circumference, femur, calves, feet. I love feet. Feet are my faves. Humeruses, forearms, hands, fluid. I think I just gave you the whole rigmarole.
That's a lot. And you know what?
Yeah.
I want moms and people here listening to know that it is so common, and maybe I'm ruining what you were going to say. It is so common for people to not get all of the views of the heart. She just said 20 views of the heart. So many times I have moms text after the 20-week ultrasound and say, hey, everything seems to have gone great. They weren't able to get a couple of the views of the heart that they need. So we've got to go back next week and try again. And so don't worry too much. Like, I don't think I've ever had anybody have that happen and then it be a negative thing. It was just simply that they couldn't get them that week.
Correct. My radiologist, I love him. So my process in my office, we do our best. We have 45 minutes to an hour to get it all done. And a lot of that's just education and talking through it. And we talk about the measurements and stuff. The big stuff, it's talked to with either their midwife or their OBGYN when the report comes. But he reads it that night. He sends the report off in the morning. So there's not a long wait. And we do our best. We don't want to have you come back. I know, especially financially, that can be a bit of a burden for people. So it's always my goal to try to get as much as possible. But sometimes he's not real thrilled with the picture, or he feels like it's something we should watch. And that's to the mom and the baby's benefit. It's not someone saying, oh, let's just willy-nilly do that. We want to make sure we're getting... Yeah, exactly. I mean, we'll make it fun and you'll get to see your baby again. And typically we schedule those 4 to 6 weeks after the first one, because we do want to give the baby some time to grow and maybe change how they're laying to get those pictures better. I also want to touch on something that, as much as we try, and I think we're really, really good, like the heart views, if I can get all the heart views well, that cancels out like 90+% of all heart anomalies, but there will always be things that we can't see super well. And I'd love to guarantee that as soon as somebody's done and they have a clear anatomy scan that they're okay. But,
there's always outlier situations for sure with everything. Yeah. And that is one of the hardest things of being pregnant, I think, is all of the unknowns. And even when you do all of the things to get the things you can know, there's still going to be some unknowns. And I think that that's just our really first dose of reality as parents of we really are not in control here.
I would agree. I mean, we do our best. We really, really do. I treat every mom as if it was my sister or my friend. I want to get the best pictures. I want to see their baby as clear as possible.
Yeah. Yeah. Okay. So that's the 20-week. Then what do we got, MJ?
So a lot of moms, that's it. They don't do more. If a mom hits 40 weeks, they typically start recommending BPPs, biophysical profiles. Some people call them baby well-being, different things like that. And it's a component, we like to score it 8 out of 8. And the 4 things that we score is fluid, heart rate, breathing, and movement. And it's the little movements. It's not the big movements that we're looking for. But on that exam, we also look at how is the baby laying? What does the placenta look like? And it's not uncommon for someone to have their 41st BPP scheduled with me and they send me a picture of a baby in the morning. We don't need it. That's beautiful. I love that.
Does that also check the way that the blood is flowing through the cord, like that everything is going the way that it's supposed to be going, or no? Not on a
BPP. We would catch that most likely on an anatomy, but the blood flow comes from the placenta to the baby and then back to the placenta. Mm-hmm. So it's a little different than how we would look at on the outside.
Okay.
So we're less worried about that. As long as we're seeing that placenta is healthy, that cord is a 3-vessel cord, or if it's a 2-vessel cord, how is that implantation done?
Okay. And then, so I'm really surprised to hear you not mention the 36-week, because so many of my hospital birth mamas get a 36-week scan, but not a whole lot of my out-of-hospital mamas do.
Correct. And I came from an environment where I did MFM, OBGYN, and we almost always did either a 34 or 36-week growth. But I rarely do them with the midwives. And I don't do as many ultrasounds for OBGYNs in the area as I wish. But I definitely do a lot for the midwives. So I think sometimes it's a follow-up, or if mom is measuring a little bit bigger, her fundal height is bigger, they may recommend a growth, but not like they do in the hospital. In the hospital, they're going to hit you with ultrasounds left and right, I think. They're like, okay, you do your anatomy, then let's do a 26 growth, and then let's do a 34 growth, and then just throw BPPs on there. Yeah. And that's kind of, they're very reactionary, and that being in both environments, they're very reactionary. Everybody's treated very similar. I feel like the midwives do a better job of hearing their moms and maybe deciphering their care a little bit better, but you also get great care with the OBGYN. It's just your
a
voice
lot of it.
Around. Yeah, exactly.
It's a little extra, and they're charging your insurance for these things over and over. And some of us don't have regular insurance. Like I don't have the typical insurance that most people have, where I have, everything is paid for and whatever, and it's all like a lump sum for my pregnancy or whatever. I don't have that. So those add up a lot. So that's so interesting that you guys heard it at the beginning. She's a huge fan of ultrasound. She loves what she does, but she's still saying, so you really don't think that on a normal, everyday, the 99% of people kind of deal, that's not like a diagnostic, in your opinion, scan?
I would love it. I would also love to see all moms like 8 to 10 weeks in their pregnancy. And oftentimes the first time I've seen a mom is at her anatomy. And I would say that the downfall of that, I understand either they're worried about exposure or they just want to keep things low profile. We don't have any way of determining the anatomy is a snapshot of that day. So they'll say, say their baby's supposed to be measuring 19 weeks, 5 days, and I measure the baby at 18 weeks, 3 days. And they're like, is that a problem? Well, we don't really know if that's really the baby's due date because we never did a dating at the very beginning, which is kind of the gold standard of dating a pregnancy. Is the baby not developing as quickly as we would like or as normal, effectively as we would like? Or is the due date wrong? And we're still only getting this one snapshot on this one day. I would definitely hope to see a mom for a growth after that, just to see if those dates, even 32 weeks, 28 weeks, give me something more. So I can correlate those two, like, your due date is actually based on that 18 weeks, 3 days. Or is baby just not growing as well as we would hope? That's probably one of the most common questions I have. Like, is the baby okay? Well, the big stuff is for the midwife or the OBGYN to go over. But things like that, it's sometimes really hard for people to get their heads around, to realize this is just today. We don't know. Or if the baby is bigger, they're like, I'm going to have a giant baby. I'm like, you're just halfway through your pregnancy. This might just be a growth spurt. So
that's what I tell people. I'm like, some babies walk at 9 months and some babies walk at 14 months. And we're not panicking about either of those. But all of a sudden, we expect everybody's baby to be at the 50th percentile at 20 weeks and at 36 weeks. That's not even possible, because if everyone's baby was at that, it wouldn't be the 50th, So that's not how this works. And really what we're worried about what we're looking for, or what everyone's looking for, is that your baby hasn't fallen off of their own growth curve. So if your baby at 20 weeks and you're just somebody who gets the 36 week because that's what or growth scan, 34, 36, whatever, and your, OB or whoever has ordered it, or even my hospital midwife clients get those a lot of times, then at that scan, they, if your baby was showing at, let's say 45th percentile in their 20 week, and then now they're showing 36th percentile in your 36 week, or maybe 58th percentile in the either way, that's not that big of a deal. But then if they were at like 10th percentile now, that's where it would be, okay, well, this could be significant that we've had a big jump and the baby maybe isn't growing at the rate that they should. Like, we're more worried about, intrauterine growth restriction or something at that point, right? Am I on track there?
Absolutely on track. The babies less than 10% or greater than 85%, I get a little anxious about, because we need to really identify. I wish I would have seen them if it's at an anatomy. I wish I would have seen them at a dating, so I knew for sure what their date was we don't always ovulate on the 14th day. The egg and the sperm don't do their dance.
Thank
They
you.
can play. Yeah, they putter. He's down there playing basketball.
But
She's
everyone
picking
gets a 40-week
flowers.
due date.
Yeah. So it's like a normal course of things. You could legitimately be 10 days off and not have a big deal. But getting, say your due date is August 10th, but it's actually August 1st. That's a big range to not allow a baby to cook and to develop, or vice versa. We think it's the 1st and it's the 10th. That we need to start talking about getting the baby out, like some ways of getting that baby, because that's going to be a big baby.
Well, what's funny though is it's probably going to be born on its own. So here I go with my naturally minded stuff, but I don't care.
100%.
I really don't care if a mom thinks that her due date is September 1st based on the dating, right? And then at the 20-week, it shows that actually maybe her due date is September 7th. I don't care because she's going to have her baby anyway. So that gives her more time. I'm sorry.
Correct.
Yeah, that gives her more time.
You were right.
But if it all of a sudden shows August 20th, I'm like, crap, they're going to want to, give her an exit plan. And she doesn't deserve an exit plan because her baby might not really actually need one, So it just is hard because we're strung up by insurance policies on these dates. And if your baby is measuring big, your baby might just come early then because your baby had a due date that was a little earlier and we just didn't know, and that's fine.
Or they're a bit of an overachiever. And that's kind of valid because my MFM land, we would deliver 40 weeks. Like I remember them talking 39 weeks, we're going to induce where baby is coming out. And that was the only environment I knew. I hadn't had any experience with midwives yet. So I didn't think anything of it. I was like, oh, I guess that's just what we do. 40 weeks. But now the last couple of years, as I've built this rapport and had hundreds of midwife mamas come through, I find that typically they deliver 41, 42 weeks. That's more of a standard than 40 weeks. Sure, you're always going to have the ones that come earlier for whatever reason, but 41, 42 weeks happens a lot and then they come, to your point, naturally. They come when they're ready, and it's a beautiful thing, and it's a great experience for everybody.
Yeah. Now, we just had a mom this morning, actually, had a baby at 41 weeks, 2 days, first time mama. Unmedicated birthing center birth, beautiful, beautiful birth, and actually fairly fast, less than 12 hours. And if she was at an OB's office who would have been pushing a 40 or a 41 week, 2 days ago, you induce her and her labor would have been 36 hours with an induction. But today, this morning, she had a baby in less than 12 hours beautifully, and like sometimes we just meddle too much. I'll get off my soapbox.
I agree. Her body was ready. Her baby was ready. Everybody was ready. Yes. No Pitocin. Let it happen.
Yeah, I agree. So what else you got for me? Did I miss anything? Did I miss in asking you anything important?
I will say people talk about getting too many scans. I've been working with a lot of women, and it's a growing area of my business with IVF and IUI, people going through fertility treatment. And it's kind of fascinating to be on that side of it and be counting follicles and to be talking about their retrieval. And you had touched on it in the beginning about they want to see their babies. I don't want anybody to feel guilty because they want to see their babies. Like I've had women come in pretty much once a week until they can start to feel their baby because they have so much angst and concern, and maybe they've had a loss. Maybe they have a friend who had a loss, and they just want to see because they can't feel. It's okay. Nobody's going to shame you. They'll come in and they'll be like, don't tell my husband. I'm like, I'm not going to tell your husband. Just know that if that helps you feel reassured that everything is all right, you should not feel bad about it. And you shouldn't let somebody make you feel bad about it. It's not going to hurt your baby. We're not going to sit there for hours looking at your baby, but seeing the heart rate, seeing them wiggle, seeing them grow, I kind of feel is invaluable. And I often have
especially for those lost moms.
Yeah, especially for them. But sometimes they're just new moms. They're just
Yeah,
nervous.
I
And
was.
I'll have moms come in. I know, I was too. You don't even want to know how many ultrasounds I got because I had a friend in ultrasound school, which is what I wanted to be doing. I know. We looked at that poor kid and he's just fine. He's a
Yeah.
paramedic. He's smarty smart. But I'll have moms mix diagnostics and electives. They'll come in for their dating. They'll come in another time or two. Then they'll come in for their anatomy. And then they'll come in for like their 3D. And like to touch on the electives, 3Ds are best, like 27 to 32 weeks. And hydration is key, whether it's
On all of
diagnostic or
these, yes.
elective. Drink water. I know it's boring. I don't like water either, but the water in your amniotic sac is a combination between what mom is drinking and what baby is producing. When baby is drinking and peeing and breathing, that metabolic process helps generate the fluid and keeps it at a good level, and also what mom is drinking. And that gives it a healthy little room to kick and roll and play and practice their breathing and all of that. Hydration, good pictures. Yes. Please drink your water before your ultrasound appointments. Not a full bladder, but being hydrated is key.
Yeah. And I'm going to touch on real quick too. You said like, don't feel bad if you want to get a million ultrasounds, right? Not a million, but you know what I mean?
Right.
And I just also want to say, I do have some moms who opt out of all of them and they live by faith and they're like, no, I'm fine. Like none of this is going to make any difference for my birth plan. I'm not doing it. It's going to stress me out. And I respect that too. So know that we're saying all of this just so if you want these, you can understand the process behind it, what they're looking for. It's more for your education, not because we're trying to push something on you.
I would absolutely agree because I have people, my neighbor, she actually didn't come to me until she was 42 weeks and we did a BPP because her midwife was like, can we just check to make sure everything is ready? And she was like, I kept seeing you drive by and you would wave. And she's like, I didn't want to have any ultrasounds, but then you reach a point where you're like, let's just make sure everything. And she ended up going into labor that night and having her baby. Yeah, it was a big baby. That was a big baby.
I love it. You don't have to worry as much about big babies, by the way. Then they're like, you're not as worried about them losing so much weight.
Yeah, exactly. He said they're going to lose weight. I have people say to me, this is probably like my own agenda thing. I'll have people say to me, well, ultrasound is a higher frequency than it has been in the past. And it is, but not under OB. And I have some facts here I want to read off. In 1990, the 2 megahertz to approximately 15 megahertz is what ultrasound was. On OB, we are typically at a 2 to a 4 megahertz. That hasn't changed in 40 years. My transducers are 2 to 4. My 3D is a 2 to 6. Those are the same. So if you go on Google and you're just like, has ultrasound frequency increased? It has, because the high frequencies are superficial structures like breasts and vascular and biopsies. And the higher the frequency, the less penetration. So if I want to look at a bump on my skin, I want the highest frequency possible. If I want to look at my baby in my belly, I want a low frequency. And somebody who's registered and experienced like myself, we know this. We're not upping the power or upping the frequency because that doesn't give us a better picture. We want low frequency. Yeah, I get probably once a week, somebody will want to have this dispute about frequency. And I'm like, but that's ultrasound as a whole. It's not OB ultrasound, which is what I typically do.
That's important information.
Yeah. I mean, just like you look up anything, you can find something that aligns with your viewpoint. So just be open. But if you choose not to, that's okay too.
Yeah. Yeah, that's awesome. Well, I love what you're doing. And I really love that people can do this outside of their doctor's office or whatever. They don't have to, do it there. Especially for people having out of hospital birth, having these options for them. I love that you have like office hours on different days in different parts of town for different midwifery groups. But can you tell people if they want to learn more about you or connect with you, how they can find you? And I'll also include this in the show notes for our listeners.
Okay. And I am offering a discount. Do I get to talk about my discount?
Of course. Yes.
So
Go for it.
25% off if anybody wants to book. You can book through the website. You can choose your location. You can choose your ultrasound. And then there's a place where you can put a discount code. If for some reason you can't figure it out, give me a call. It's super easy. I'm typically the one answering the phone. I have See My Baby Live as my website. Phone number 512-662-3621. My diagnostics are run out of SMB sonography. Some of the cool things for us is we are hoping to start taking insurance in the next 6 months. And we are also planning on being able to offer some blood testing. So kind of big stuff. I'm kind of a firm believer of making things affordable and being competitive and available. I have later hours often during the week. I'm pretty flexible. I don't want everybody to do this, but I had a mom call me a couple of weeks ago, like 10:30 at night, and she was like, I'm bleeding, I'm terrified. And I said, wear your pajamas because I'm wearing mine. And we met at the clinic. I mean, I can't guarantee I'll do that.
Work. I know. It's like so hard, right? This is heart work.
Yeah, exactly. And I knew she wouldn't sleep and I knew she was scared, and it's a gift. And I have a skill that I'm really proud of that I've been honing for over 13 years. I want to make a difference. I love making a difference. So
I love that. And see, I told you guys, you'd be able to hear her passion right through her voice. Well, thank you so much for being here, MJ. I can't wait to get this episode out and for people to be able to hear you. And go ahead and check out the show notes, guys, for that discount code. And I'll talk to you next week. Bye.
Thanks, Sierra.
Thanks for listening. If you enjoyed today's episode, please take a moment to follow, rate, and review the podcast. It helps us reach more families who can benefit from this resource. For more resources, classes, and services, head to empoweredbeginningsatx.com or check out the Birth Baby Academy at birthbabyacademy.com. Until next time, wishing you confidence and calm on your journey through birth and beyond.